Hello and welcome to Back to the Science. I'm Dr. Susan Oliver and I'm a scientist, and this is Cindy Oliver and she's a dog. Okay, so a few weeks ago, I made a video about an allegation made about a doctor at Lucy Letby's press conference in December last year. The claim was that the doctor had accidentally killed a baby by sticking a needle in its liver, and that Lucy Letby was therefore innocent. One of the things that I pointed out in the video was that there was evidence that the liver was bleeding several hours before the doctor inserted the cannula. Letby supporters were not impressed and claimed that I was wrong. But that was then. This is now. And Letby supporters agree that the liver was already bleeding prior to the procedure because Dr. Shoo Lee told them so. In fact, Dr. Lee says the liver injury actually occurred during baby O's birth and just happened to start bleeding when Letby was left alone with the baby 2 days later. Anyway, more on that later. If you're wondering why multiple media agencies are suddenly jumping on the Lucy Letby is innocent bandwagon and uncritically accepting as fact the opinion of new defence experts that completely contradicts different defence experts from December, it's part of a slick PR campaign. The PR company, Maltin PR, actually that's Maltin PR, is counting on journalists being too lazy to do their own research and instead just parroting their PR release. But I know what you're thinking. 14 world-leading experts said this, so it must be true. Who cares that the experts at the December press conference said something entirely different? It doesn't matter because we've got the best experts on the case now. We know that because Dr. Lee told us they were.
First of all, the panel that we have is, as I said, this is the top notch in neonatology. This is the creme de la creme.
I have to say, I did have a little chuckle when I heard this description of the experts because the exact same words were used to describe Lucy Letby by Erin Powell. And this is a description of her that was challenged in the Thirlwall inquiry. She was asked the following. When you were first interviewed by the police, you said that when Lucy had qualified, you had no qualms about employing her. Even during her interview, although I can't remember much about it, I wanted her on the unit. I really did. When students come through the system, you are almost able to handpick the creme de la creme, and she was one of those. We have had evidence now that she failed and had to have a retrieval replacement in her final year at university. She had the clinical incidents that we have gone through, and there was a period of 3 months where you understood she wasn't doing what other nurses who were qualified would be doing. How was it you came to describe her as creme de la creme with that history at that point? And by the way, one of the clinical incidents they are referring to is when Letby accidentally set a morphine drip at 10 times the recommended dose. Thankfully, it was just before she went off shift and the next shift picked it up quickly. If they hadn't, it would have been another baby death caused by Letby. Now, of course, I'm not suggesting that Dr. Lee's experts are the same type of creme de la creme as Letby. I just thought that it was rather hilarious that he used the same phrase to describe his experts as was used to describe Letby when it was known that she had failed her final placement and made many clinical mistakes. I am sure all of Letby's experts are very competent, as are the tens of thousands of other neonatologists around the world. However, there's no evidence that they are the best in the world, as is claimed by Dr. Lee. They are just people that he personally knows. An eminent neonatologist who wasn't included on Dr. Lee's list was Professor Johan Smith. Professor Smith was the clinical head of the Neonatal Intensive Care Unit and Tertiary Neonatal Services of the Department of Paediatrics and Child Health, Stellenbosch University and Tygerberg Children's Hospital in Cape Town, South Africa. He founded the United South African Neonatal Association together with Professor Alan Horn. And in addition to being a neonatologist, he also has a PhD in the field. Now, you may be wondering what Professor Smith has said about Lucy Letby. As far as I know, nothing. I don't even know if he is aware of the Lucy Letby case. So why am I mentioning him? Because Professor Smith is lead author on this paper here, which details 4 cases of neonatal air embolism by accidental IV injection of air. In one of the cases, the baby experienced skin discoloration, which was described as follows. The infant's skin turned blue-black with blotchy redness. The feet were extremely pale. Why is this relevant? Well, because according to Dr. Lee, there is no such case in the literature.
And in the new paper that I had published in December of 2024 in the American Journal of Perinatology, a copy of which will be in the summary report that you will receive, we actually separated the cases with arterial venous air embolism from the cases with venous air embolism. And what we found was that in the cases where air was injected into the veins, there were no cases of patchy skin discolorations ever described in the literature.
Now, you may be wondering how Dr. Lee missed the paper by Professor Smith when he did his literature review. The answer is he didn't. He just decided that he knew better than Professor Smith about the cause of the air embolism that Professor Smith was reporting. And the reason I know this is because I added a PubPeer comment to Dr. Lee's review paper questioning why he hadn't included this paper. And Dr. Lee explained very eloquently why he thought he knew better than Professor Smith. Now, I am not a neonatologist, so I am not going to argue with what Dr. Lee has said. But I would like to point out that he has made an assumption in his explanation that isn't actually in the paper. According to Dr. Lee, this was a preterm infant with severe respiratory distress syndrome who was intubated and mechanically ventilated. An intravenous line was in place to provide fluids. The skin discoloration was observed while the infant was being transported to another hospital. But the paper doesn't say the baby was being transported to another hospital or that the baby was mechanically ventilated. It says, the infant was intubated and transported to the neonatal intensive care unit for mechanical ventilation. En route, the infant's skin turned blue-black with blotchy redness. The feet were extremely pale. The attending physician thought this was a reaction to the intravenous fluid and replaced it with 0.2% saline and glucose 5%. Now, of course, Dr. Lee's interpretation could be correct. It's possible that the neonatal intensive care unit was in another hospital. But it's also possible that they were just wheeling the baby down the corridor to the NICU and the baby was being hand ventilated. Regardless, Professor Smith clearly knows a lot more about the case than Dr. Lee because he was the lead author on the original paper and he had no reason to be biased in his assessment. On the other hand, this is what Dr. Lee told a journalist about the review paper that he wrote.
I mean, the other thing that he did very deliberately, as he told me, in a sort of attempt to create that kind of new evidence genre that seems to be required by the Court of Appeal, was that he updated his 1989 medical paper to make it really clear in the cases that he'd looked at that the skin discoloration was not present in the case of venous air embolism, which is, of course, the way in which the air was injected into the veins of those children concerned. There's a difference between venous air embolism and arterial air embolism. And he published that paper just before Christmas. And he said to me very clearly he had done that in the hope that his new paper could be submitted as fresh evidence.
And there was another case of possible air embolism from IV injection where skin discoloration occurred that Dr. Lee chose to categorise as something else in the review paper that he deliberately wrote to help in Letby's defence. In response to my pub peer comment regarding this case, Dr. Lee stated the following: the infant was on CPAP and supplemental oxygen, etc., etc. But if you go to the original paper, it says treated with nasal CPAP and supplemental oxygen in the first hours of life. The air embolism was on day 12 of life. So clearly the baby wasn't on CPAP or supplemental oxygen at the time of the air embolism. And we also know that skin discoloration occurred in one of the babies that Beverly Atlett tried to murder via air embolism. I guess Dr. Lee is not familiar with this case. Now, why does any of this matter? Because Dr. Lee is trying to dismiss the skin discoloration seen by the parents, the doctors and the nurses on babies that Letby murdered as not being related to air embolism, and therefore suggesting that the babies died from other causes. In doing so, he is ignoring the other evidence of air embolism, including air in blood vessels on X-rays and air in tissue samples from the brain and lung. And he also thinks he knows better than the people who were there what they saw.
Had these skin discolorations has no evidence in fact, all right? None of this actually has ever been described. If this is true, it would be the first case ever described, but it's never been. And there's a reason for that. The reason is that in the arterial system, when you inject air into the arterial system, it goes directly to the skin or the blood vessels or to the organs. Whereas in the venous system, it has to go to the lungs first. And the lungs has a complex bed of very small blood vessels that filters out all the air bubbles if they come through, so that they don't actually get to the arterial system. Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system. But it has to go against pressure, because the pressure in the arterial system is higher than in the venous. And so what we found in the literature was that there were no cases that have been described where, in fact, these skin rashes have occurred. So let's do away with that theory, all right?
Right. So according to Dr. Lee, the pressure differential will stop air bubbles from travelling through a patent foramen ovale, or PVO, from the venous system into the arterial system. And that's why the skin discoloration seen in the babies that Letby murdered weren't from air embolism. That's complete bollocks. PVOs are literally diagnosed by observing tiny bubbles introduced by IV pass over from the venous system to the arterial system on an echocardiogram, although obviously these bubbles are too small to do any damage. And ironically, the international experts claimed one of the babies had died from an undetected blood clot blocking blood to the brain. This could only have happened if the blood clot passed through the PVO from the venous system to the arterial system. So we are meant to believe that an air bubble couldn't pass through the PVO, but a blood clot could. And we are meant to dismiss skin discolorations that had never been seen before or since by the doctors and nurses, to dismiss air found on X-rays and to dismiss air found in tissue samples of the brain. But we should accept that a blood clot blocked air to the brain, even though it wasn't found on post-mortem. The experts have apparently come up with explanations other than murder or attempted murder for all the babies where Letby was charged, although only some were shared in the summary report. No idea why they didn't put the others in. Now, it's not remotely surprising that the experts were able to do this because that's how Letby got away with so many murders before she was caught. No one wanted to think the unthinkable, so they were able to convince themselves that something else was causing babies to unexpectedly die when Letby was around, and only then. After all, the babies were on the neonatal unit for a reason. And in the case of Dr. Lee, this was his brief. What they said to me was that you have literally got to find a different person or thing that caused the death. So that was a brief, and this is what they came up with for one of the babies. The baby has always been known as Baby I, but Dr. Lee and his team have instead decided to call her Baby 9 instead. And they've done the same for all the babies. Instead of using the letters that the babies are now known as, they've changed them all to numbers.
All right. Now, the next baby is baby 9, where the allegation is that the baby received nasogastric tube air and then subsequently was also given air through the IV in the intravenous system, which caused air embolism. Now, baby 9 was a preterm infant with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease, who had repeated episodes of apnea, desaturation, and bradycardia, needing resuscitation during the hospital stay. And the baby was in hospital for quite a period of time. The baby also had an episode of lung collapse and reports that there were thick gelatinous airway and oral secretions. And one of the registrars, who is a mid-level doctor in the NICU, stated that it is not unusual for babies on breathing support to get secretions, but it was a bit unusual for them to be so stubborn at being removed like in this baby. And after each period of apnea and desaturation, they had to resuscitate the baby using back and mask ventilation, and then the abdomen was distended. And abdominal x-rays taken after that showed gaseous distension of the intestines. At 2.5 months, she had an episode of severe apnea, bradycardia, desaturation, and heart block, and then deceased. So it was alleged that air was injected into baby 9's stomach through a nasogastric tube, leading to recurrent episodes of abdominal distension, which then splintered the diaphragm and caused respiratory arrest and failure, needing resuscitation. It was also alleged that on the 13th of October, that the apnea alarm was deliberately turned off, resulting in delay and response to a collapse. And that on the 15th of October, air was injected into her intravenous tubing, causing air embolism and death. So we looked at this case in detail, and what we found was that baby 9 was a very preterm baby with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease. Also, that in fact, surveillance cultures, which are normally done after a baby is admitted to the unit from outside, to make sure that there are no dangerous bacteria being brought into the NICU. So they routinely culture all these babies after admission. And in this case, the surveillance culture revealed a bacteria called Stenotrophomonas maltophilia, which is a gram-negative bacteria from her endotracheal tube. And the doctors in the unit were duly notified that that was the case. Now, this particular bacteria is unique because it is a multi-resistant opportunistic pathogen that can colonize the airway in biofilms that are resistant to antibiotics and impossible to clear in patients with chronic lung disease. The thick secretions can block the endotracheal tubes, which led to the endotracheal tubes constantly being blocked and replaced, and interfere with ventilation in the small airways of these vulnerable infants, which together with other factors like chronic lung disease can lead to recurrent episodes of apnea, desaturation, bradycardia, respiratory failure, and collapse. And the colonization with Stenotrophomonas maltophilia would have further compromised her ventilatory capacity. Now, her initial abdominal distension was likely due to sepsis causing ileus, or to lactose intolerance because there's a family history and the stools were positive for reducing substances. But the subsequent repeated abdominal x-rays showing intestinal gaseous distension were all taken after resuscitation and bag and mask ventilation, so that the air was likely introduced by the resuscitation, not because the air was there previously. Also, a nurse explained that the reason that the apnea alarm did not sound was because the apnea alarm is set to go off if there is a 20-second period where there are no breaths. But because this baby was gasping at less than 20 seconds each time, the apnea alarm wasn't triggered. So it wasn't because it was switched off. It was because the baby was gasping, and so it wasn't triggering the alarm. Right. Now, this baby was not treated for Stenotrophomonas maltophilia, and there is no evidence that air embolism was at all involved. We concluded, therefore, that baby 9 died of respiratory complications caused by respiratory distress syndrome and chronic lung disease that were complicated by the Stenotrophomonas maltophilia colonization. The doctors failed to respond to routine surveillance warnings that this baby was colonized with this bacteria. They did not recognize the diagnosis. They did not treat her with the appropriate antibiotics which would have cleared this bacteria. This was likely a preventable death. There is no evidence of air causing splinting of the diaphragm or of air causing air embolism. There was no evidence that the alarm was turned off. In fact, the evidence is that the alarm was not turned off.
Well, that sounds pretty damning, doesn't it? Well, it does if you're not familiar with the case. If you are familiar with the case, you are wondering how these experts could have done such a sloppy job. First of all, the stuff about the alarm not being deliberately turned off is a red herring. One of the many prosecution expert witnesses, Dr. Bowen, specifically said at the trial that after hearing the nurse's evidence, she agreed that the alarm had not been switched off. So I've no idea why this was even mentioned in the report. More alarming, though, is the bacteria Stenotrophomonas maltophilia that Dr. Lee suggests is implicated in baby I's death. It sounds extremely concerning that the doctors didn't treat it with the appropriate antibiotics. Well, it sounds alarming if you're unfamiliar with the difference between colonisation and infection. As this article about the bacteria states, it is crucial to differentiate between non-invasive colonisation from non-sterile samples and an actual infection that warrants treatment, mainly by the clinical judgment on the symptoms, signs, laboratory and radiographic evidence of infection. And there is a very good reason why you don't just give powerful antibiotics to babies who don't have infections. And that's because you don't want to contribute to antibiotic resistance, which is a huge problem worldwide. But you're probably thinking, how do I know that the baby didn't die from an infection on the 15th of October? Well, that's simple. Baby I didn't die until the 23rd of October. After Baby I's collapse on the 15th of October, she was transferred to Arrow Park Hospital, where she made a quick recovery before being transferred back to the Countess of Chester Hospital on the 17th of October. And she continued to do well at the Countess of Chester until Letby was back on shift on the night of the 22nd of October. Just prior to Letby getting her hands on Baby I, her heart rate and respiratory rate were satisfactory, while her temperature and oxygen saturation readings were optimal. Baby I was also not receiving ventilator support. So the idea that biofilms were blocking her ET tubes is total bollocks because she didn't have any ET tubes at the time. Now, I'm sure that the experts have by now realised that they have totally stuffed up on Baby I and are working on another plausible sounding hypothesis that doesn't include murder, and Letby's PR team will feed it to the usual unwitting journalists who will conveniently forget this little stuff up. Just like they conveniently forgot the previous hypothesis about baby O's liver injury and now uncritically accept that the liver injury occurred during birth and just happened to start bleeding 2 days later when Letby was left alone with the baby. Of course, there is lots of evidence that also shows this hypothesis is wrong. To start with, at 9:30 a.m. on the day that Letby murdered baby O, Dr. Cook undertook an abdominal examination, which revealed that the abdomen was full but not distended and was soft and not tender. This examination effectively established that no liver damage was present at the time of this examination. And then, of course, we have the evidence of Dr. Marnarides, who is a perinatal and paediatric pathologist who is trained in forensic work. Unlike a neonatologist, he is qualified to determine the cause of a liver injury from detailed photos of the liver. And he was very clear that the damage to the liver was from inflicted trauma. And he provides lots of detail about the liver injuries, explaining how he came to this conclusion. He also said, "So I have only seen this extensive hemorrhage in 2 babies' livers of children, not babies. In road traffic collisions, in accidents with bicycles, the wheel against the abdomen, that can cause this. And I have seen it in babies in the context of cases not in the neonatal care unit, babies that have suffered non-accidental type of injury, typically with other injuries to the abdomen and injuries to the brain." And this again comes from transcripts purchased by the owner of the Crime Scene to Courtroom channel. The experts who compiled the international report said the following, however: blunt direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in liver protected by the lower chest wall. Now, I'm sure this sounds convincing to some people, but really it's just showing that they have no forensic expertise, because these type of injuries to livers have been seen in babies that were deliberately harmed, and they have been seen by many, many forensic pathologists, including Dr. Marnarides. Curiously, they were also seen in one of the cases that Dr. Lee referenced in his literature review on air embolism. I guess he missed that bit. And it's not surprising that abusers can damage the livers of babies, because, contrary to the claims made in the international experts' report, the chest wall doesn't protect most of the liver in newborn babies. And neonatologists have to know this. So it's quite bizarre that they claimed otherwise in their report. It's also worth mentioning that although the international experts had a lot of neonatologists, they didn't have a pathologist, they didn't have a radiologist, they didn't have an endocrinologist, and they didn't have a hematologist. All these specialists and more presented evidence that supported Letby's guilt. Neonatologists don't have the necessary expertise to overrule these specialists, particularly neonatologists who don't have any forensic experience. So, in summary, it's easy for experts to come up with hypotheses that seem to fit the evidence if you look at them uncritically. That's why most medical serial killers manage to get away with it for so long. You need forensic experience and the correct specialist to detect murder, not colleagues of a doctor whose evidence was rejected by the Court of Appeal. If you'd like to look further into the data I've presented, I've provided links in the video's description. And please remember, this video is about the science, but you shouldn't take it as medical advice. For that, you should speak to your medical practitioner. If you've got this far, thank you for listening. And if you've liked, shared, or commented on the video, double thank you, because that helps the algorithm. It means that more people will see the video. And of course, thank you to everyone who has bought me a coffee or little Cindy a treat. Cindy, she's asleep. She's not going to have a treat. Yes, she is. We really appreciate your support. We will be continuing to make videos about the science in the future. So if you'd like to join the cool kids and stay informed, please hit the subscribe button. Thank you.